everyone. I'm Etione Aldarondo, Director of the Melissa Institute for Violence Prevention and Treatment. What a pleasure it is for me to be here with you today, to see you all and new friends jumping in the screen there and signing up and witnessing this wonderful event. Today is particularly meaningful for me, not only because Dan is a distinguished researcher, an innovator who was doing research on family therapy outcomes before other people were doing it. He was doing family process work before people even knew what that word really meant. He was a proponent, a developer of cultural competence models, when at a time when people did not really know exactly what that meant and how it could help other communities around the country. He's above all, he's been through his life a pioneer, an innovator in the integration of research and practice, always thinking about how can science really improve and enhance the strategies, the ways in which clinicians have to work with very difficult families. Any of you who know Dan knows that the work that he's been doing over the years has always been with the most difficult clinical situations, and continues to do so until this day. So for that, the whole field is very grateful to Dan. Now, what makes it even more meaningful to me is that I really have an immense amount of affection for Dan. He's a good friend. I've been a colleague for many years at the University of Miami. He started in the School of Medicine, then to the School of Nursing, the School of Education and Human Development. So he's been around the university, and we're blessed to have had him at the university for as long as we had. You can read more about his bio in the information and the package that you have. And just one more thing that I could let you know is that once you listen to him today, many of you will have another chance to kind of like learn and engage Dan. If you fast forward a few more weeks and you sign up for our annual conference on May 6th on safety, mental health, and healing during uncertain times. Dan will be talking at that time of issues of self-harm and a lot of really, really difficult things that are going on in our world and our communities right now. So without further ado, I'll leave you with Dan.
Thank you. Thank you for that extraordinary introduction. It's very meaningful for me. You're not supposed to make me emotional during presentations. But I mean, thank you, Etione. The work of the Melissa Institute is so extraordinarily meaningful. And it's such an incredible pleasure for me anytime that I can participate with you in any of these events. And before we start, I want to say that these past couple of years have been very, very difficult for the kids and the families we work with. And we want to give a very, very heartfelt thank you to all of you out there who are doing this really difficult work. And it's during a time that we ourselves are going through a lot, right? Because of the COVID, because of lots of other things going on in the community. And we're just extraordinarily grateful. I want to make sure that you know that for all the extraordinary work that you do. So I hope that you can see my screen there okay. We're going to be talking today about culturally informed and flexible family therapy. It's a specific intervention that I've been working on for some 20 years. But outside of that specific intervention, I really want to talk about some of the tools, the interventions, the strategies, right, that we all need to use, whether or not you use this particular model, right? And so I've really spent 30 years at the University of Miami, but 20 years specifically on this particular model. And I'm going to share with you in an hour and a half or so the 20 years of experience. And hopefully it comes across as something that is still in progress. We are constantly trying to improve it. but that we think is really effective with some of the most challenging, right, processes that we encounter. After I left the University of Miami, we started this group, Training and Implementation Associates. And as I'm going to explain to you in a little while, the issue was that, it's one thing to have an evidence-based treatment that works, but it's a whole other story, right, to make it sustainable in the front lines of practice, that your agencies can keep it and do it well and feel good about how it's being delivered over time. And those challenges are the ones that this group, that our new group has begun to work with in partnership with the National Institute of Mental Health and NIMH to try to solve some of these challenges. So today we're going to talk about, three sets of things. One is that I'm going to try to talk about some of those challenges to implementation that are so very important if we want our kids and families to get the very best service over time, right? We're going to talk about some of the cultural content that I really feel should be part of any treatment and any evidence-based practice. And we're going to talk a little bit about specifics about how I believe these things get incorporated. And then we're going to talk specifically about some of the components of the model and how you work with an adolescent individually, how you work with a family and family processes and dynamics. As Dr. Aldarondo said, it's a very complex work, and to do it well, we have to have well thought out strategies as well as good training. But we're going to talk about all of those three things today. So let's start with the idea that, of course, our goal is to have the very best quality services, right, for the diverse youth and families that we treat. And funders and agencies have increasingly been turning to evidence-based treatments. And I believe in evidence-based treatments, and I believe in them because they have certain advantages. One, for example, that is clear is that these treatments tend to have evidence on how they work, right? And when the evidence shows that it doesn't work for a particular subgroup, it helps us to improve it because that's what we target for improvement. They tend to have very detailed training protocols. They tend to have manuals with very detailed steps and tools for how to implement the practice. It has explanations of what kinds of changes and in what sequence you can expect, right? And finally, when the evidence shows that for a particular group, it's not working well, there are often adaptations, very formal adaptations of the manuals so that it's a better fit, right, for a unique population. I think that the protocols that we have in evidence-based treatments really allow new therapists to get up to speed on a new treatment. We don't all have the luxury of trying to go through a whole master's program, right, to learn a couple of new treatments. Typically, we see something that works and we want to learn it. So the extent to which these interventions have very specific protocols and tools to make it learnable and to help us master, right, the competencies, it becomes very important. Now, one of the things that I want to talk about, however, is what are the challenges, right? Because while I'm an advocate for evidence-based interventions, I believe that our history shows that there's been a lot of problems with evidence-based treatments, and we need to, be able to address them. So one is, for example, that when you see a young person like this, these symptoms, these problem areas do not tend to be independent, right? They co-occur. So that term co-occurring disorders, co-occurring problems became one of the mantras recently, right? In the past decades. And we rightly say that co-occurring disorders is the rule and not the exception, right? So we can pretend that we are working only with a self-harm youth, right? Or a depressed youth, or a youth with aggressive and violent behavior. But the more we dig under the surface, we see that a lot of these things are connected. We have a program now working with youth that are self-harming and pretty serious, suicide ideation, behavior. But there's no way to talk about self-harm and the risk of self-harm without talking about substance use, for example. Substance use will potentiate on any particular day. If there's substance use, there is a higher likelihood of self-harm, right? We can't talk about these things without talking about the family and the extent to which when family conflict exists, it's going to enhance, right, the self-harm potential of the youth. Depression is an obvious one here. And one of the other ones that we talk about quite often is emotion dysregulation. And emotion dysregulation tends to be under the surface of a lot of these things. So any particular treatment that we consider really needs to be able to talk to how it might target several of these things at once. One of the weaknesses of evidence-based treatments tended to be that they sounded like they dealt with one thing. This is a manualized treatment for substance use. This is a manualized treatment for depression. And that's not really the case. It has to be prepared, right, to talk about what underlies these things and how co-occurring disorders tend to have a certain synergy, right, a syndemic effect where they intensify each other. A second challenge that tends to be very important is that evidence-based practices have not always been great at integrating, right, the unique experiences of some diverse and minority populations. Things like immigration and acculturation stresses, racism, marginalizations of many types, right? And so many evidence-based treatments tended to talk about the mechanism of change, whether it's cognitions, whether it's family processes, whether it's emotion regulation, but almost in isolation of what is going on with these kids in the real world, right? And so we believe that this tendency to avoid issues of culture, diversity, and contextual stressors has been a mistake. And so a lot of the work that I've done over the past 20 years is to show how an evidence-based intervention can integrate issues of culture. And hopefully I'll be able to show you concretely how that works. You know, when interventions don't mention and don't put at the forefront these issues of unique stressors, they tend to be considered to have a low ecological validity. So Bernal and partners talk about this issue of ecological validity, that a treatment should make sense, right? If I begin to work with a recent immigrant and I'm able to talk about, smartly within my treatment about immigration stress, that's going to have ecological validity for the client. Because they say, okay, your content, what you're talking about is what I believe is real for me in my life. And so that I believe is very, very important. This particular monograph by La Raza on bridging culture and evidence really makes some of these arguments very nicely. Now, the third, and I promised you sort of three challenges. And so one was, the co-occurring disorders issue. One was the issue of integrating culture, right? And the third one really, I believe, is the issue of sustainability of evidence-based treatments. I've worked over the years with so many, right, treatment agencies, directors, associations, networks, and they want badly to have very good services, right, and to use the very best evidence-based, research-supported interventions to help families. But they taught me something very, very real, and that is that sustaining these treatments is not an easy endeavor. One of the reasons is that it's difficult to learn and feel confident in a new treatment. Typically, even if an agency brings an expert out, right, for a 2 or 3 day training conference, the therapist leaves excited about that intervention. It makes sense. There's logic to it. I see the connection to the work that I do. And yet, when they leave, it's not like they are totally ready to implement that intervention. And in fact, you're creating anxiety in the therapist who really wants to implement a new treatment and is unable to. there is some fascinating research by Ahrens showing that when an agency puts a lot of effort into having their new staff deliver a brand new intervention without ongoing support, right, from the experts on that intervention, it creates stress and can even bring about staff turnover. So imagine that we're creating a partnership to improve services. Everyone's excited about the new intervention, but there's not enough funds for the ongoing support. Well, that's going to fall apart and perhaps might even, according to this research, bring about staff turnover, which is one of the biggest problems in the field. When I saw those data, it really inspired me to go more into this implementation science field because it's a problem that we don't often talk about. Agencies also have high rates of staff turnover, right? In one of the recent studies that I saw, some agencies have up to 40% of turnover in a year or two. And so imagine that you train a workforce, right? But 30-40% of the people leave. You almost have to start from scratch, right? It's that difficult to sustain it over time if you have staff turnover. So that's something that I believe we need to address. We can't make believe it's not there. Yeah. And of course, there's a lot of organizational factors, right? Organizational readiness, ways to work, to use resources, to establish champions for this new intervention, to reduce caseloads while you're learning these things, and having coaching time. And so these are all parts of that third challenge of implementation. So I wonder if we could put up this poll. I don't have the poll indicator here, but I wonder, Lisa, if you might be able to put a poll up. So what has been your experience and opinion regarding manualized and evidence-based treatments? And you can click all that apply here. We'll give it just 30 more seconds, see how we do here. We are up to about 60% or so. All right, so let's see what we have. Can everyone see? Hopefully everyone can see the screen that's being shared with you. Evidence-based and manualized treatments as very rigid and not allowing clinical flexibility. We have 34% of individuals perceiving manuals that way. Very effective, 43%. Don't deal with issues of ethnicity, race, LGBTQ, etc., 57%. Okay, so that's one of your concerns, and it's certainly a concern that we have. How do you integrate these issues of culture into an evidence-based treatment? Nice to see that difficult to learn and implement is quite low, so it's 11%, so excellent. Their manuals can be very helpful in implementation, 43%, difficult to sustain and practice, 37%. Okay, so that one, difficult to sustain and practice here is lower than I've tended to find when I work with administrators and leaders, but we could talk more about that as we go. Fantastic. Let's pull this off. So as Dr. Etioni mentioned, and what it really sounded like is that I've been around for a long time. I'm getting old. I was at the University of Miami for 30 years, but this particular trajectory of work has been over the past 20 years. And as you mentioned, we've really worked on understanding symptoms that are common in many diverse populations, understanding core family and cultural processes, developing and testing evidence-based treatments. So, we've shown the data on how and when it works. And then finally, at the end, we're going to talk about this new area that we're working with, which is creating innovative online training and implementation platforms to deal with some of those challenges on sustainability. So let's talk about this second goal a little bit, and one that's really consistent with what you all said, which is how can cultural content, right, the uniqueness of Black youth individuals, Latino youth and individuals. We're working quite a bit with Haitian families now. We're working with LGBTQ youth, particularly many are coming in around the issue of self-harm. The rates are very high among LGBTQ youth, and they have very unique stressors within the family system, often, not always, but often, that a good therapist has to be prepared to work with, yeah? So I showed you this graphic a little bit ago of a youth that has depression, self-harm, substance use, etc. But the reality is that if we're going to talk about this more accurately, we have to think about some of these factors, right? Racism, anti-Latino sentiment, services that are not culturally informed, right? Because they are the foundation or the background, right, in which we're seeing these specific issues of self-harm and depression. So, for example, can you really work with a youth who has some self-harm behavior and substance use if he or she is experiencing racism on a daily basis, right? And can you really do the work without having that conversation, right? If you're working with a Latino and they're experiencing lots of anti-Latino sentiment, how can you do the work on the cognitions or whatever that is around depression without being prepared and being adept at eliciting, right, the conversation about anti-Latino sentiment? It's impossible to do that. And so the trick here is to make sure, right, that we are working, that we have on our radar all of these things so that we're doing our work as effectively as possible. So let's talk about something very specific, right? Around racism, for example. And we often hear about parents giving their kids the talk, right? About how to survive, right? How to be okay in a racist environment. But imagine you see down at the bottom there that you see that some of these kids are often involved with family conflict because of their symptomatology. So let's think concretely. Can a family really be effective at leading, at being protective with their kids around the issue of racism if there is family conflict already existing? It becomes more difficult, right? Our research shows us that it becomes more difficult. So if we can think along all of these dimensions, right, we appreciate that one of our very first steps is to reduce the family conflict so that protection that the family is capable of is there for the kids around the issue of racism, right? The advice that parents give and the mentoring that parents give around issues of racism or anti-Latino sentiment are going to be much more effective if we have reduced the family conflict that makes the parents less credible. So I want you to see how this all interacts and interfaces almost in a, Bronfenbrenner-like ecological map, right? Because they all exist there. And the more an intervention can tell you, this is the way we think, and this is how things link together when I'm trying to deliver family interventions, right? To reduce conflict, to enhance the power that parents have with their kids when they're talking about racism, when they're talking about other stressors in the community. This is what it looks like practically speaking, right? And so when we do our family work, this is the conversation we have. When we introduce psychoeducational material, it's around these things: discrimination, racism, protection. And hopefully I give you some more examples of this. if I'm going to take seriously this issue of accepting that there are certain processes that are important in therapy and treatment, right? Engagement, retention, having good outcomes, I still have to ask the question, how do culture-related factors and processes impact these processes? And to be totally honest with you, whatever success I had and my team had in bringing about grants to the university to study these questions and to publish on these issues, it's because we needed to get as specific as possible, right? Sort of, amorphous, general ideas don't work, right? We had to talk about specifically how do these things work. Engagement, if you're going to work with families, engagement is, of course, is one of the most daunting challenges, right? To bring individuals that are overburdened, have two jobs, have a lot of reluctance and distrust of therapists, right? So this issue of engagement is an important one. We all accept that. So the first question for me is, okay, and how does culture and race interact with that, right? So when I'm working with Latino, Haitian, recent immigrants, for example, we must be able and capable and effective and competent, right, at eliciting, hearing, validating, right, the difficult immigration experiences, the traumas, and the acculturation stressors that they're going through. And by the way, it doesn't mean that you have that up here, right, that you say, oh, yeah, that's important. That's an important concept, but that we practice, right, it becoming words, that we are comfortable eliciting conversation about immigration and trauma around immigration and the trauma of acculturation, right? It has to come out smoothly, because otherwise, families will just avoid the topic. They will feel that the therapist is not ready or competent to have those discussions. And so they end up avoiding things that are really important to them. The more that conversation comes easily to a therapist, the much more likely we are that we're going to be successful with engagement. So, about 2 weeks ago, I was asked to be on a panel, and even an old guy like me can learn. And there was this excellent therapist, Black therapist, Alan Lipscomb, and he was doing a presentation on how to enter in a relationship with a Black client in an effective way that's anti-racist and anti-oppressive, right? And I thought, and he gave specific examples of what a therapist might say, right? And so I thought that's exactly what I've been also stressing, that we can't keep it conceptually, as part of something we understand, but that we have to practice words, right, that allow us to be effective in conversations that are, quite frankly, difficult. Yeah. And so I want to share with you some of what he shared with us, because I think it's really helpful. So he put out some words that a therapist might say. And some of this might be a little jargony. And for any of us, we have to say this in a way that is comfortable to us and that is comfortable for the kids and families we work with. But think of the power of these statements. I acknowledge that I enter into this space with levels of power, privilege, and authority based on my identity. What is my identity? As a, well-trained therapist, as a professor at a university, as a master's level, very experienced therapist, right? That I come in with privilege and authority based on my identity, role, position, because I work at X place. I realize that you may or may not trust me, the system or the process. My hope is that with time, I will demonstrate to you that I am someone who is here to support, collaborate, and honor you in your path. And by the way, one of the things that became really, really important to me, because many of the adolescents that came into our program were referred by juvenile justice, right? And one of the very first things that I wanted to teach the therapists that work with me is it is to be expected, right? That some of the kids and parents that come to you will feel coerced into coming into services, will not trust, the juvenile justice system, and by extension, right, we are seen as an extension of that system. And so we must be, right, prepared, not defensive, non-judgmental, competent at having this conversation. And so I thought that this statement that Dr. Lipscomb shared with us was just, powerful, right? Again, how do we say that in our own words, but that we understand it? Your truth is centered here. If at any time I miss something or you find that I don't understand because I am different from you on some dimension, please know that I'm fine with talking about it and I will not take it personally. So that is part of the work that I do. I get to and must continue to work on growth in this area. And so, to have an open conversation with cultural humility, right? About, hey, we might be different on this dimension. Tell me when you think that I'm not getting it. We can have that discussion. I value that discussion and I will learn from it. And we will both be better for that. And so I just thought, some of these very concrete, because sometimes we're missing concrete examples of what does this look like. You can't get more concrete than this, right? How to open a relationship, how to open a dialogue that will deepen a relationship between a counselor and the family and the youth, and that will keep them in therapy because they see ecological validity to this and they see value to this. There's an interesting area, and again, I'm just trying to give you examples, right, about how cultural things interact with family processes. So in our work with Haitian families recently, with Latino families for many years, we get to see this dynamic in action, and it's very powerful. Typically youth and parents, what this graph shows so far is that there's typically intergenerational differences, right? My kids will always have thought that I was a dinosaur, and behind the times because of our generational differences, right? That's just to be expected. Now, when families and kids are acculturating, right? When they come to this country, what happens is that kids tend to acculturate much more rapidly, right, than their parents. They pick up things. They pick up a worldview here in the United States that's different from their parents. And sometimes it looks like, right, they're rejecting their culture of origin. And that's painful to parents. And so in addition to intergenerational difference, over time, what we see is that is multiplied, right, by intercultural differences. So in addition to whatever gap existed there on intergenerational difference, now it's blown up because they have different worldviews that are developing. And what we find, in our clinical work as well as in the literature, is that these generational plus cultural differences can quickly lead to lots of family conflict. Yeah. We need to know this so that we're prepared when we're dealing with families, when we're trying to help these types of families, to see it, to think about it, to normalize it, right? To say, hey, this is what happens, right? This is normal. It's not a personal rejection by the youth of your culture, right? It's a normal process, but let's talk it through. Let's talk it through so that the family can learn from this process, and we can talk about how to take the best of both worlds, right? And become bicultural. But without knowing the concepts and understanding them and feeling comfortable with them, it's unlikely to work well. Yeah. So as I'll show you later on, we have a module, a psychoeducational module just on this issue, right? And so when we run into a family, a Haitian family, any immigrant family that is struggling with this, we will have a psychoeducational module that the therapist can read, be prepared to present to the family, to normalize, yeah, and then to work it through in the family. I want to share with you just one of the other things that we found that's really important and that you'll see often in our community is parents and children who have been separated due to the immigration process. And lots of this work has been done by Suarez Orozco and Suarez Orozco. They have a very nice book on this issue with many of the dynamics that you find here. It struck me at one point in my career that I didn't really think along these lines, and many families who had gone through this didn't emphasize that this was the case. They had by now were trying to reunite, and they didn't talk a lot about their separation. And it just struck me when I realized that we had to open this can of worms if we wanted to help the family. We had to be able to talk about this. In some of our, once we identified it as something that happens often, we found that the families who have been separated have been often separated for almost 4 years, right? The separation happened between the age of 7 and 11 and 12. And these are some of the things that occurred under the surface in the family, right? Children feeling abandoned, resentful, feeling guilty for having those feelings. And I'll just let you take a look at these. Again, the importance of this, and we have a module for this, right? So that if a therapist asks the question, have you guys ever been separated? And by the way, separations occur around immigration, but they can occur for a lot of other reasons also, right? When a parent is imprisoned, there is a separation, and there is later, hopefully, a reunification. When parents go to the military, right, for service, and they return long after, there is a reunification. There is a reintegration of these family members into a family. I got to be honest with you, the expectation is that it's a happy moment. Sometimes it's super sad and painful because it's stressful, because they weren't prepared to learn how to integrate again. There's lots of feelings that folks aren't prepared or weren't equipped to process. But we as therapists, right, have to be thoughtful about how do we help families through all of these complex feelings. The more prepared we are, right, the more likely we're going to be effective. So I hope that these are very concrete examples of how, manualized and evidence-based treatments can still, right, have at the forefront issues of culture, acculturation, race, ethnicity, right? It should not be an add-on at the last minute, right? What happens with some therapies, right, that they don't mention culture at all? There's an expectation, right, that the therapist will be culturally competent, right? And that layer will be brought onto, whatever therapy they're doing. But that's a lot of work for a therapist. That's a lot of complex work. And why my argument, right, to the field has been, why doesn't the evidence-based practice build that in already, right? If I'm working with families, I need to understand, if I'm teaching family therapy, family systems, and I'm going to implement it with recent immigrants, right, I need to know ahead of time how some of those experiences cause breakdowns in the families. It makes more sense to talk about it from the very beginning. And so that's what we've sought to do. Before we move on to talk about the specific components of the intervention, I just want to say a little something about protective factors and resilience. We recently were asked by the Children's Trust to create a course on issues of protection, and we focused on a model called Strengthening Families Framework. And so it really struck me that some of these things are things that we don't always talk about. It's easy to talk about pathology and high-risk factors, right? But, we, to be effective, need to be thinking about protection as well, right? And if we're lucky enough to work with families, we have a lot of protective factors in families that we're not always used to identifying and enhancing, but it's really important work. So it occurred to me that sometimes we think about risk and protection as sort of two sides of the same coin, right? Someone either has risk factors or they have protective factors. But the fact is that protective factors and risk factors exist at the same time. And I just thought that it was important to make that point. And we just finished football season. There's a lot going on. And so here's a couple of examples about risk and protection. So think of shutters on windows in the middle of a hurricane as protection, right? In the middle of that risk of the hurricane. We have, unfortunately, in the world, a war going on right now. And here is an example that's, important today, right? There are folks come in with a certain level of protection, bulletproof vests, right? Because they're going into an environment that's very, very high risk. There's bullets flying, yeah? And so, let's think of football helmets in a football game, yeah? I don't walk around with a football helmet and when I come to do lectures. I mean, I think I would look actually pretty interesting with a football helmet right now. But that's not what we do, right? But in the middle of a football game, when you have the risk of heads colliding, right? That's a risk moment where a football helmet makes sense as a protection, right? Notice again that this is not about you being either or, right? With risk or protection. You put up shutters when a hurricane is coming. The hurricane is the risk factor and the shutter is the protective factor. Yeah. The key to protection is that sometimes we cannot make the risk factors disappear, right? I don't have control over the hurricane that's coming, right? I don't have control over the head damage that's going to occur in a football game if no one has helmets. But we can, right, think about how to increase resilience and protection. I actually, when I had this discussion with the children's trust agencies and therapists, and we realized that this is a hopeful thing for us. There, and we see poverty, and we know that we can't change that, right? And we see racism, and we know that we can't change that. And it becomes really important for us to stay with the idea of protection. And I think that makes us more hopeful and gives us more tools to work with. So this is just a way of thinking that you cannot have protection without risk, right? A characteristic, risk factor is a characteristic that precedes and is associated with a high likelihood of problem outcome. A hurricane coming through is very likely to have bad outcomes, right? Damage to your property and to persons. A protective factor is something that reduces the negative impact of the existing risk factor, yeah? So if we can't eliminate the risk factor, we can still focus on the protective factors. I gave you an example a little while ago, right? About kids that are living their lives in the midst of anti-immigrant sentiment, in the middle of racism, things that we can't rapidly change, although it's our job to change those things. But we cannot rapidly change, but we can think of protection. And how do we strengthen families and strengthen youths to be resilient in the face of those things, yeah? So I actually wanted to take a moment and ask you to put in your chats things that you see as important in terms of these like risk factors and especially protective factors. Things that when you're working with kids and families, that these things stand out as something that you can and should work with and might even become better at working with to provide protection for kids and families. So I'm going to take a peek at our chat and just feel free to put some of those in and I'll share them with you. And you see a graphic there with sort of a ecological map, right? Peers, church, environment, schools. What are things that are risk or protection in those contexts? I see advocacy in the system, very important. For adolescent, peer relationships. And peer relationship can be stressors, right? Stress factors, risk factors. They can also be protective, right? If they're hanging out with the peers that are actually strengthening, right, and supporting them. So the advocacy one is an important one. So a big part of the family work that we do, because we know that kids are often in underperforming, let's say, schools, for example, and families have the ability, right, to be advocates in those systems. Kids are going to be better off the more parents can advocate for them. And so that's part of the family strengthening that we can do, right, to help them become better advocates. Now, I want to give you a really interesting caveat here, is that culturally, right, it's been documented that in many culture groups, there is a worldview that one should be very respectful of institutions, almost defer, right, to institutions. So we may be, right, asking parents to go to those systems and fight for your kids, but we have to be attuned, right, to whether there's a cultural piece there that says, that's not, I don't know that that's correct, I don't know that I feel comfortable challenging that system, right? And so that's an important conversation for us to have, because we need to meet families where they're at on this topic, yeah? So that piece of family becoming effective at advocating for their children is a really big one, and has lots of cultural components to it. Acknowledgement of loss and grief and subsequent support. That becomes protective, right? So I gave you the example of kids and parents who have been separated for long periods of time. There's going to be lots of, right? Some of the sessions that we've heard, overwhelming amount of pain and sense of loss when they've been separated for years. And the only thing that we can do, right, is to mobilize that protective piece of the family dynamic, which is around acknowledging, validating, right, that pain, and then moving forward. That as painful as that work is, it is what deepens the relationship and allows the family to truly reunite and move forward. So I see school dynamics that are unsupportive, certainly risk factors. Social media, boy, that's a big one. We're actually creating a module just around social media, because it was very helpful during COVID, right, for us to stay connected and seek support. But wow, are there lots of risk factors for kids around social media? And boy, does the family have to be attuned, mentoring, and protecting kids around the risk factors that come around social media. Absolutely. But yes, families can be ostracized from their own communities for speaking up against systems. That is such a big one. Think about that. Families ostracized within their own communities for speaking up against a system. So the community, which might be my support, that's an important support that I have. But if I speak up, I lose that support. That's a very challenging place to be. That's a very interesting comment made by one of our participants. Absolutely. So let me just read through some more of these. Point of original assistance in family. So very good ones. I appreciate your participation. I hope that just by you seeing some of the other comments that people have, that it's valuable to you, because these are right on target in terms of the kinds of things that we must be thinking about as we are juggling, as we are doing our work and understanding the dynamics that our families and kids are juggling. Yeah? So this is just sort of a wrap up on this. We must always ask the question, if we can't remove the risk factor, things like poverty, racism, is there any way to enhance protection, right? If you can modify the risk factor, let's do it. That's the main thing we should do. But we always are thinking also of enhancing protection. And just remember, please, that we are not always trained to think about protection. Yeah. Okay, so I want to make sure. I'm going to start moving a little faster. So this is all of that work that I've described over the past 20 years has culminated in this intervention that we have, culturally informed, flexible, family-based treatment for adolescents. It's on the list of interventions that the Children's Trust wants to see implemented in our community. It's being implemented in a number of areas. As I mentioned, with Haitian families in the Miami Gardens area, in the Little Havana area. Here is, as I mentioned earlier, ways in which CIFFTA tries to integrate, right, cultural factors, right, by talking about the things that I just talked about: immigration stress, acculturation, discrimination, stigma, right, about seeking services, protective factors like familism, right, thinking specifically, right, about ways in which cultural factors integrate with the mechanisms of a treatment. These are all in the manual. It's not an afterthought for later. We believe that you see flexible in the title of CIFFTA, culturally informed and flexible, right? Because this is not a one-size-fits-all, right? There is no way to be quote-unquote culturally competent with any group and to have an intervention that has A, B, C, D components and that's going to be effective for everyone. It just doesn't work that way. Why? Because of what I have here, right? Adolescents have different symptoms: self-harm, depression, emotion dysregulation issues. There's cultural uniqueness, right, for kids and for parents. Some more acculturated, some less acculturated, and we have to be prepared to talk about that. And then, of course, the unique stressors that I mentioned earlier. So as I'm going to show you in a little bit, the issue of flexibility is that there's lots of modules that tap into these issues and that can be selected, right, by the therapist. That gives the therapist power to tailor the intervention by providing these specific tools and resources. And of course, we are family focused, and we believe that that working with families is the way to have the most impact. There's major risk and protective factors in the family, right? Families can reinforce changes that the adolescent, positive changes that the adolescent shows, or they can invalidate them if they're not prepared to help the kids in that new behavior. And as many of you mentioned, the family can advocate, right, for the child in an environment that could be risky or hurtful to the child. So, I believe in working individually with the kids, and you're going to see that we have individual and family components. But without a doubt, our assumption, our strong belief is that if you can help the family to enhance itself, its processes, the kids, they're going to be there for the kids long after we as therapists are helping the kids, right? They're going to be there long after, supporting, validating, mentoring. They will be in a better place to mentor the younger peers, right? So that's why we believe family work is so important. Challenging, right? Because we said, engaging families is not an easy task, but it's the most powerful thing we can do. When we teach things about family work, I always try to remember that we should keep in mind that a family has a family life cycle. Yeah. Individuals are individuals, right? As an individual, I tend to think about, what do I like? What do I want? Am I going to have a career of this type or that type? When I connect with someone as a couple, I have to develop a new side of myself, right? I may have been great as an individual and I may be horrible as an intimate partner. Yeah. I have to develop a whole new side of myself. And then the same happens when one becomes a parent, right? It doesn't matter how good I was as an individual and as an intimate partner. I have to develop a whole new side of myself as a parent. Yeah. And that's hard work. And if we have conversations with families who are in really tough situations and we don't validate how hard it is to make these transitions. And by the way, all of us run into very young kids who are already parents, right? And who all of a sudden are thrust into that role. And it's hard work, and we have to validate that for them. That parenting role, that parenting side of us doesn't really come to be until there's a child right in front of us. And then we better be good parents, right? And so, and it happens often in a rapid transition. And so understanding this issue of how an individual has to expand and learn and grow and to be good at the next role and then be good at the next role of parenting. I think it's humbling, right, to us. And it really helps us if we normalize this, right, for parents and say, this is really hard work. There really is no manual that everyone is given, right, when they with the child. And so, we're going to work to figure out how to make this work for you. Yeah. There's a sports analogy for me, right? I love basketball. That's one of my passions. I spent all my life playing basketball. But what if somebody tells me, tomorrow, well, you think you're a good athlete, right? And you're pretty good at basketball. I want you to play hockey. I'm going to be a mess. I'm going to look horrible because that is a side of me that I've never developed, right? And it doesn't matter if I was a fairly good athlete and fairly good at basketball, right? The analogy to this of being a pretty good individual and a pretty good intimate partner. But we have to acknowledge that the minute that we're going to go into a whole new field of work, and parenting is one of those, right? That it takes a lot, right? And we cannot be expected to be good as we move forward into that new role. So here is CIFFTA, and here are the components that we have built in. We believe in individual work with the adolescent. We believe strongly in family therapy. And we believe that psychoeducational modules allows us to have a certain level of flexibility, right? So that it's not a one-size-fits-all approach. At least warn me, you better give some specifics because our audience likes specifics. So I'm going to give you some specifics. What does individual work look like, right? We believe strongly that motivation enhancement and motivational interviewing is one of the most powerful things one can do with an individual. Yeah. I'm hopeful that all of you have been exposed to it, that have received some training in it. It's a standalone, right? It can be a standalone. You can, work with that as a standalone intervention. We happen to have integrated it into CIFFTA because we think it's that important. That we not push people to create change in their lives before they're ready. That we take time. The minute that you learn motivational interviewing, you learn that you have to go slowly, that you have to meet people where they're at, right? You don't want to insist on change when someone is not sure that they want to change. They're not sure that their drinking is a problem. They're not sure that their eating habits are a problem, right? So there are very specific steps that one can take to be most effective, right, at bringing about ultimately behavior change. But very important in our work. And when we train people on CIFFTA, part of that training is on motivational enhancement. Goal setting, emotion regulation. Emotion regulation for us is a really big one. right? And it's at the foundation of violent behavior and aggression. It's at the foundation of self-harm, right? Violence towards self. It's at the foundation of many, many issues that kids have. And there are interventions that can really be effective with emotion regulation. We didn't want to reinvent the wheel, and we knew that one of the nicest emotion regulation skills trainings came from the work of Marsha Linehan in dialectical behavior therapy. She's done beautiful work on this issue of skills modules for emotion regulation. And there's one for interpersonal effectiveness, right? So how do you help kids become more effective at identifying what they need, right? How do you differentiate a need and a want? When you need something, how can you communicate it effectively? And how can you effectively get it from the people that are important to you? Yeah. So these are very specific skills that we believe that if you're working with young kids and with adolescents that are just learning this whole thing, right, of emotion regulation and interpersonal effectiveness, that those skills can be very effective. Yeah. So we integrate that into our modules. We have those as modules. And then we bring it back and work on it in individual therapy. So we have a list of some, by now 20 modules. My team laughs at me because every week I come in with, I think we have to develop this. And the latest is on social media. But the important thing is that one would never be expected to deliver all those things to every kid and every family. The therapist gains the power, right? The use their clinical expertise to say this family has these three issues really prominent, and here are a couple of modules that can be helpful. So I integrate that into our modular session day, and then after they've learned it, right, we're also going to talk about it in family therapy and individual therapy. The generalization phase. How do you build it into, once you understand it, how do you build it into your daily life? The modules really became the key for us becoming a flexible therapy, but flexible and giving therapists the tools, right? It's not like I said, hey, by the way, your kid has emotion dysregulation problems. Go figure out how to help with that. The idea here is that if we accept that is a very common issue in many of the adolescents we work with, the therapy should have a built-in tool for them. Yeah. So I want you to remember that this is CIFFTA, but even if you believe if you don't buy the idea that this entire package is what's necessary, I'm trying to convey, right, what we have learned over the years can be very powerful for working with kids and with families. Okay. So you might, if you don't want to do this whole intervention, you might think about how to integrate some of these pieces into the work that you do. Then we go to family, right? Reducing conflict, increasing support, repairing ruptured relationships, right? I don't know how many times we get families that come in and they say, well, that relationship is gone because, this and this happened and they don't believe in me anymore, and that's just gone. And we say, was that relationship important to you? And if they say yes, a family member or a youth, we say, okay, let's figure out how to fix that. Because one should never drop for the rest of your life a ruptured relationship that can potentially be meaningful and supportive. So these, in a nutshell, right? These are the main things. And I have sort of a wheel structure here because I do not believe that any of these by themselves work as effectively as if you put them together and create synergy, right? So with the youth, they might be interested in emotion regulation or being effective interpersonally. And we'll teach that in the module session. In individual therapy, we might talk about, well, did you use that in your daily life with your peers, right? And we'll talk about that. That's generalization. But more importantly, in family therapy, right, when they start getting into a conflict, we're going to want to say, hey, let's pull what we learned. Let's generalize it right here. And at that moment, we begin to modify, to shape the child's behavior and the family's behavior so that it reinforces, right, the new things, the new improvements, the new enhancements that the kids are working on. And so it becomes very important that there be synergy. This is a big table. It just shows you all of the ways in which we do adolescent work, family work. And on the left, it shows that we sort of think of stages, right? That there are stages of things that you do. There are certain things, tools that you use when you're wanting to engage, certain ones that when you want to increase motivation, right? And then you move forward in time through stages to get all the other work done. Too much to talk about in a lot of detail here. I do want to say a little more about the process of tailoring, and this is what it looks like. We end up using data, a clinical interview, any other measures that agencies collect. We use it to create a profile for any youth and family. And we try to figure out what are the high points. That is, what are the things people are struggling with. And if you see at the bottom here, you see, this particular case had depression, conduct problems, some risky sexual behavior, actually very little risky sexual behavior here, but school problems. And then you see that there's some acculturation related things. There's big gaps between the parents and the kids on acculturation. And so what happens then, based on this profile, is that we go to our modules, our menu of modules, and we only have a subset here, but there's lots more, even self-harm and things like that. And then we select, right, for this kid, which is the more important one. And by the way, if we're really good therapists, we don't just select it separate from the family, right? There's a shared decision-making process by which we have a conversation with parents. And we say, hey, this is what you told us. This is what you have said has been a problem. We have these modules that we can bring in so that it facilitates our discussion. What do you think about that, right? So now the selection of modules is a shared decision-making process that is very, very likely to strengthen the therapeutic alliance, right? By making a shared decision-making process, it will improve therapeutic alliance, right? So in a nutshell, this is what the whole tailoring process looks like, and we want to make it predictable, systematic, and replicable, yeah? So that other therapists can do it fairly easily and have all the tools needed. For our therapy, our counselors tend to be master's level counselors. Depending on the severity of the symptomatology and the family circumstances, treatment can be once or twice a week. And these are some of the things that we have worked with, substance use, self-harm behavior, more on the prevention side with younger kids, etc. I don't want to get too much into the whole evidence for the intervention, but we're listed on the California Evidence-Based Clearinghouse, the National Registry of Programs and Practices, NREP. We have a number of articles that we've published with very specific, populations, always very diverse populations. We just had one published that showed how it is particularly effective with folks that are describe themselves as less acculturated, right? And so our ability to talk about some of those processes that you saw earlier around acculturation gaps, around separations, appears to be particularly effective. And so this 2022 article was published in the Journal of Family Process, should be coming out in a month or so. And these are the kinds of things that we look at as evidence, because we can't have an evidence-based practice if we don't have evidence, right? It's not okay for us just to say that there's evidence. So this was a particular study with substance-using kids. And the comparison condition, the kids showed a little bit of deterioration. Their drug use actually went up. from the beginning to the end of treatment, but very little, not a lot. But in comparison, our CIFFTA condition showed a lot of drop in the drug use. And this was not only self-reported drug use, but also urine analysis corroboration of the reports. How do we change drug use? We believe that we do it through family enhancement of family processes. So we had the question: Are the parents more involved? Right? Are more attentive, validating, working with the kids? These are kid reports, by the way. These are not parents saying I'm doing better as a parent. We ask the kids, how are your parents doing? In the comparison condition, not a lot of change from beginning of therapy to end of therapy. In the CIFFTA condition, we were able to show that the kids were saying, my parents are with it more. They're with me more. They're working through my issues. And so for us, that was very important evidence, if you will. Sometimes testimonials are even more powerful than numbers. And these are just some of the things that supported the idea that we were, in fact, changing families, right? Changing family processes. One of my favorites is this one. The mother saying, she and the counselor clicked from day one. I don't know what happened. Next thing I knew, she was like, Mommy, do you know that? And then the mother stopped and thought, she hasn't said that since she was 8. So that's particularly powerful for us, because it means that whole issue of ruptured relationships, of deepening relationships, it's real, right? As described by families. Okay, so now we're down the stretch run, and I'm hopeful that you've seen some of the challenges, right? I'm hopeful that you've seen some of the ways in which culture can be integrated into an evidence-based practice, how an evidence-based practice can integrate individual, right, family work, psychoeducational work in a way that they are creating synergy, right? They are feeding on each other and supporting each other. We believe that's very important. And again, family therapy is complex work, right? It doesn't come easy, right? And if we don't do it well, if we try to work with families that are high conflict, for example, high negativity, and we are not prepared to do that work well, we are more likely to not only not help families, but if we let them fight and hurt each other, we may do damage. So I'm a strong believer in family therapy, but I'm a strong believer that we have to be well equipped, right, to work with families if we're going to get down and dirty, right, on some of the most powerful and painful issues. One can do psychoeducational work with families, and that's a choice. If one is not well trained in family work, you can still do some work on psychoeducational and things like that without getting into the negativity. But I believe that the place where that you can be most effective is by getting into the pain, trauma, and loss that families have experienced. So, having a treatment that works is only the first step. See, I got to my career like 20 years in of the 30 years, and I was pretty happy. I thought we had a pretty nice evidence-based treatment, and I was a supporter of other evidence-based treatments like dialectic behavior therapy, like motivational interviewing. I was always trying to help people learn those things. But agency directors and therapists taught me something really important. And that is that having the evidence-based treatment is only the first step, right? Just as important as having evidence-based treatments is having an evidence-based way of training, coaching, and implementing the interventions so that they are sustainable over time. Yeah, it's sort of equivalent to the issue of the vaccines that have taken over our lives recently, right? Having a vaccine is an incredible accomplishment, but at some point people said, okay, now we have the vaccine, but how do we get shots in arms, right? How do we really get it out there in a way that deals with people's hesitancy, beliefs, what are the mechanisms that it takes to really get it out there, now, then later boosters. And so the mechanism for getting things out and keeping them in place are just as important, right, as developing the initial intervention or the initial vaccine. There's a whole field at that point when I had that, epiphany, and I realized how important this was. Then I realized that there's a whole field called implementation science. And they have all the evidence of everything that goes wrong, right? More goes wrong than goes right if you leave it to chance. If you just say, I'm going to disseminate this, I have this great product here, use it, more goes wrong than goes right. And so there's this whole field of implementation science that does research just on this issue of getting things out to the field. Yeah. There's some extraordinary lessons that have been learned. But here's some of the challenges that I talked about at the beginning and that continue to be issues. Very high rates of staff turnover, right? And what happens? You have an agency, they have 10 therapists, 10 counselors, they bring an expert on whatever, trauma-focused CBT, right? Motivational interviewing. Everyone gets trained, right? But a year later, a quarter of the folks have left. Sometimes they leave for another agency or another career, but sometimes actually they get promoted within the same agency, but they're no longer at the front lines of that in that unit, right? Delivering the service. So all of those things are important. So then what, right? The agency now has to try to bring the expert back in for this new 4 staff, and then a few months later it happens again. So from a sustainability perspective, it's a huge problem. There's lots of issues of lost staff time, billing hours when people have to go to therapy, have to go to training. One of the most important things, and I mentioned it earlier, I can give you a presentation on CIFFTA for 2 days, but that's not sufficient. You might see the value of it. You might understand some of the tools, but learning the family therapy and to deal with the really powerful processes with high severity families, it takes ongoing relationship and coaching and support, right? And then there's obviously organizational factors. What we try to do with TIA is to create an online learning platform, because we just don't see any other way of keeping up with the needs in a way that's more cost effective, right? That an agency can actually say, I can afford that particular online training and keep some money aside for my new trainees to get coaching and support. And so we've been working with the NIMH, National Institute of Mental Health, with lots of agencies in our community to figure out just what is the best solution to this. Now, online platforms, the minute that you hear that term, sometimes your eyes probably glaze over, because every time I take an online thing, it's like PowerPoints that are really bad, and I passively, either look at it, read it, or hear something. The idea was that this had to be very interactive. If we were going to do this, it had to be highly interactive. So to solve the first problem, high rates of staff turnover, the idea is that, if you have an online system, they can go on at any time. When the new staff comes on, they orient themselves immediately. It can be done at the convenience of the trainee. To deal with this issue of people feeling uncomfortable that they haven't practiced, right? I went to a 2-day, I did 1 role play, I didn't really get to practice. We have created simulated families, and I'm going to show you some in a minute. They're actually cartoon simulations, and we spend a lot of time creating real family processes that we have learned are difficult for therapists to handle, new therapists, and we built it in here so that trainees can learn to see certain things in process. This is part of the training. Learn to see certain things in process. And then we ask them to deliver an intervention recorded on the system so that they practice what they would say. Do you remember at the very beginning of my presentation today that I said people have to practice? What would they say to a Latino family with trauma in their immigration history? We talked about Dr. Linscomb and what he said. How do you practice? And he said it specifically, how do you practice saying these things so that it comes naturally, right? Now, in this system that we created, that's what we're creating, that a therapist can interact with these animated characters and practice what they would say. Our animated characters bring up issues of race and racism and challenge the therapist to, what are you going to do with that, right? But it's nice to be able to do it in this context before we actually sit in front of a real family, right? I hope you'll have a lot of comments and questions about this now when we finish and we have a question and answer. And finally, I think this enhances the ability of coaching afterwards. Remember, I believe, and the field of implementation science has proven that this coaching piece cannot be ignored, right? It cannot be ignored. It has to be done carefully. And so part of the idea of this is that as you practice with the online system, it reveals what areas of coaching any particular therapist needs, right? Again, it's not a one-size-fits-all. I might catch components A and B and master them really quickly and be able to deliver them. And yet C is difficult for me, right? Component C, dealing with that issue of race, that's more difficult for me. Now I know from my profile what really we should focus on coaching so that it's much more helpful and targeted. Yeah. All right. So I'm going to show you, this is one of our animated families. On the left, you'll see a therapist. You'll see a daughter, a mother, and a father, right? They're going to get into a conflict. And believe me, I used to train therapists. I used to be behind a one-way mirror. Etione will appreciate that whole part of our history, right? When we used to do those things. And when a trainee went in with a live family and we were behind the mirror and we would comment, right? We would see how they would handle it and the therapist would come back out and we would have a discussion. So, the value of that is that the therapist felt for real, right, what it's like to be in the middle of those strong riptides, right, when a family is fighting. I thought, right, our group thought, can we create that in animation? I want therapists to feel the anxiety because I want to tell them, what would you do with this family on the spot? Don't just listen passively to it, but think about what would you do with this family? So I'm going to run it and tell me, think about, right? Reflect on what you're seeing.
How are things this week? Cynthia took the car keys in the middle of the night and took our car for a ride with friends. What is the big deal? I was sick of our fighting and I needed some space. You don't even have a license. Dad, do you think this is such a big deal? I have driven with you before.
Don't ask me. I give up.
Very typical of him. Typical of you to attack Dad. I wish you would stop.
A lot happening there, right? And these are real families. And this is why one needs to be equipped to be able to understand what's happening, to know where to intervene and where not to intervene, right? Where not to be caught in the riptide, how to get out of the riptide and be helpful to the family. I'm going to run it once again because there was a lot there, and it's quick, and I'm going to run it again.
How are things this week? Cynthia took the...
Oops. Apologize.
Car keys in the middle of the night and took our car for a ride with friends. What is the big deal? I was sick of our fighting, and I needed some space. You don't even have a license. Dad, do you think this is such a big deal? I have driven with you before.
Don't ask me. I give up.
Very typical of him. Typical of you to attack Dad. I wish you would stop.
So for a trainee, we would ask them record, just like I'm speaking to you now, say what you saw in that session? How would you diagnose the processes, right? And later we would say, where would you intervene and go ahead and deliver in a recording? And then our experts take that recording, give feedback, and then they could practice it again. What would we try to teach? I'm going to run it real quick again.
How are things this week? Cynthia took the car keys in the middle of the night and took our car for a ride with friends. What is the big deal? I was sick of our fighting, and I needed some space. You don't even have a license.
Up until there, it's a decent dyadic conversation. And this is what we would try to teach the trainees. You can do a lot with this conversation. Mom said you don't even have a license. Let's stay on that. What does that mean? What's your concern? What's your worry? How are you trying to protect your daughter? The problem is,
Dad, do you think this is such a big deal? I have driven with you before.
In family therapy, we teach that's triangulation, bringing in another family member to disrupt the dyadic conversation. If we feel that mother and daughter have to work out that issue and that we want mother to be able to say how she wants to protect her daughter, bringing in father, who she knows has a different opinion, is a problem. It derails, right, the conversation. So this is what we're teaching trainees, right? So that's a point. That's a problem, and you want to modify that.
Don't ask me. I give up.
Very typical of him.
So father gets now a chance to say, I give up. I'm hopeless about this family, right? Which is a whole other, right, piece of work. But you can't have all of this jumping at once. There's no way you're going to be effective. And then mother, of course, says, typical of him, right? Very, typical of him to drop out of this important process and not be a good parent.
Typical of you to attack Dad. I wish you would stop.
So hopefully you see the value here of teaching process, how to read it, how to decide where you need to intervene, and then later, saying what would you say? If the intervention has to be, I need to block the daughter from bringing Dad in, I have to learn a way to say it in a way that's respectful and effective, right? I have to block daughter and say, that's a great point. I want to bring your father in a minute, but I would love for you and your mom to finish that conversation because you were talking about some really important things, and I think I can see where you can work this out, and then we'll come to father. That's like a block, but you have to feel good about being able to do that. You have to feel good about being directive. You have to feel that you said it in a respectful way. That's all practice. Right?
Howard.
Let's take a look at this one that describes a little bit about the overall way to work.
Hi, I'm Vicky, and I am going to be one of your trainers. I would like to give you an overview of our adaptive training model. Our adaptive training model offers an innovative approach to training and focuses on competencies that are at the core of our CIFFTA family therapy. We will train you on what you need to know, how to better understand what you see and hear, and what you need to do with a client in order to be more effective. Under what you need to know, we will give you the concepts and general information about our 5 core counseling competencies. Under better understanding what you see and hear, we will show you how concepts and processes typically display themselves in a counseling session. And under what you need to do, we will show you the implementation of skills and techniques to successfully modify the maladaptive patterns. Adaptive training tailors the training to the unique strengths and weaknesses of the learner and uses different methods to introduce training content. Our innovative use of simulations allows us to introduce training content in the context of realistic clinical situations. Here is Alex, one of our trainers, introducing a very important intervention technique called reframing.
Reframing is one of the most important skills for reducing negativity and transforming the discussion into one that is more constructive. A good reframe acknowledges the pain and distress being felt by the family members, while at the same time offering a more nuanced and positive explanation for the behavior. Let's see what this process looks like in a family therapy session.
My husband is always bugging me about my drinking, always calling me an alcoholic. It really upsets me.
It sounds like he really cares about you and is concerned, although he expresses it in a way that upsets you.
In this example, the therapist responds with, "It sounds like he really cares about you and is concerned." That's the caring and positive message. But then the therapist adds, although he expresses it in a way that upsets you. Notice how both sides are acknowledged. Including both messages is the key to a good reframe.
With adaptive training, you will progress at your own pace, and each step of the learning process will be adapted to what you have already mastered. We think that you will enjoy our innovative and engaging approach to training.
So let me see if there's one more that was, because one of the things that we feel is, not that we feel, that we know from the field, is one of the biggest challenges, right, is engaging family members. And we've published a number of articles on specific ways of engaging, and they happen to be the most used in the field because, and you know, we realized that this process of engaging is a really hard one. And so what we did was we identified what some of the most likely, right, most frequent types of reactions are to engagement and reluctance to engagement. Because we think that if we can teach the therapist to identify quickly what the client is saying, really hear them, right? Why they're reluctant to come in, we can be much more effective at intervening with a successful engagement. If we don't fit like a lock and key our specialized intervention to what really is being said, it's unlikely to work. So I'm going to run this. It's going to have a couple of different reactions by clients, and I want you to think about what you hear, and I'll probably just share with you what it's meant to reflect.
In this video, we will present several simulations of family reactions to starting treatment and engagement efforts. After each simulation, you will be asked to identify the pattern of reaction that is reflected.
Hello, Mrs. Smith. I left you a couple of messages, but have not received a response. When do you think you will be able to come in?
I know our son has some problems at school, but we never requested counseling. It was the school counselor who started the whole treatment thing.
Hello, Mitt.
Right? If we hear carefully, here is a person who is expressing some level of resentment at being coerced into coming into treatment. The way to engage that person is going to be very different, right? If we can read that correctly, right? Our way of engaging successfully is going to look very different from these others.
Mrs. Jones, do you think you can bring your husband to the next family session?
I don't think he wants to come in. He always finds an excuse. There are some issues he just doesn't want to have to talk about.
Hi, Miss.
The fact here that there is another family member that doesn't want to come in, one of our key questions is, but does this caller, does this woman that we just saw on the screen, does she want him in? Sometimes they are in agreement that he shouldn't come in, and the intervention for that is different than if she really is trying to get him in and he is the only one who's reluctant. Very important piece of diagnostic in order to know what's next.
Mrs. Gomez, as we discussed, we very much look forward to seeing the entire family at the next counseling session.
My husband and I are willing to attend, but our son Pablo is refusing to go. The last 2 times we had sessions scheduled, he just didn't come home from school on time.
Hi, Miss.
When you work with substance using kids and with many other sort of issues, you get this profile a lot. That you have a very powerful adolescent who is capable, right? Who has the power to not come to session even when the parents are together on their desire to bring the kid in. The engagement of that adolescent is very different, right? If you side with the parents and you keep trying to cajole them in the same way, the kid is likely to continue to thwart, right, the therapy attendance. You have to reach out directly to the adolescent with specific ways when you think that it's a very powerful adolescent capable of staying out of therapy.
Mr. Perez, how soon can we set up our first appointment to deal with your son's situation?
I think things are pretty stable. He will be okay. I think we should wait because I don't think this will get worse. Let's just see how it goes.
Hi, Mrs. Sanchez. We look forward to seeing you and your husband at the next counseling session so that we can meet with the entire family.
I'm not sure why I need to go. It is my son who is acting up. I am not crazy or depressed.
Hi, Mrs. Lopez.
That statement, I'm not crazy or depressed, should be a red flag, because many of the families that we work with that have a cultural perspective, right? It can be an individual perspective, but sometimes you have the cultural layer as well, that therapy is for crazy people. They'll tell you straight out if they want to be honest with you. And so when you hear something like that, why do I come to therapy? I'm not crazy or depressed or anything. I know it's for my kid, but it tells you something about how you need to meet them where they're at on that perspective that therapy is for crazy people. You cannot just go past it.
As we look forward to seeing you, your daughter, and your granddaughter at our first counseling session so that we can meet with the entire family.
I'm starting to have second thoughts. We have tried everything, and there may just be no hope. Carmen gets worse every day, and she will never change. She just doesn't care about me or her mother.
Hi.
That grandmother is an individual who's expressing hopelessness, right? Hopelessness is something that's really big among many of the families we work with. And instilling hope is one of our main tasks, right? And so you need to be able to hear it. And you need to be able to hear that, I don't think this is ever going to change. I don't think she cares about any of us, right? There's a lot to unpack there. But the hopelessness piece is the thing that we have to identify and work on. If we try to just use the strategy of, okay, but let's just come in for a session, it's probably not going to work because we need to address that hopelessness. And by the way, I want you to see that we are breaking down, we are unpacking the first, 3 minutes of a therapist's contact with the family, right? And that if we can read it and react correctly, we're much more likely to get families to engage and come in. But think of that. All of these examples are things that might happen in the first few minutes, right, of your contact with the family. And we think it's critical that we handle it correctly if we really want them to get excited about coming into therapy and willing to come in.
Mrs. Sanchez, if I gave you an appointment next week, will the whole family be able to come in?
No, Grandma will not be able to come in.
Is there another time when she'll be able to come in?
No, she won't be able to come in. She's very busy.
I see. Does she work? We can be flexible with the appointment time.
No, but I don't think that would work out.
So what we try to teach here is that sometimes it may be.
In this video, we will present several.
Sometimes it may be that this person on the phone call saying that grandma can't come in actually prefers that grandma not come in, right? And what we want to avoid is the therapist saying, okay, but we could do this. Okay, but we could do it. Okay. And not read that, what the therapist should say is, how do you feel about grandma coming in? If she came in, would things go okay? You think it would make an improvement, or are there some things that might happen that are not going to be great? Right? Now I'm validating that this person may have some concerns, and then I'm willing to, non-judgmentally talk about it. So anyway, I'm going to stop there, but these are just some examples. I'm hoping that I can give you these examples of ways in which we can learn very concrete, right, ways of intervening, but reading the situation. This is what really we learned in this whole process, that learning to read the situation make us much more likely to use the right intervention, right? A very wise therapist said way back, if you see clearly, you will know what to do. And so this is part of what we're trying to convey. So I think I'm going to stop here. And I just want to, again, thank you for all the amazing work that you do. You know, children and families are really in need of what you do. And we want you to know that we appreciate you. Donationi.
Yeah, let me see. Am I coming on screen?
Yes.
You can see me. Okay, all right. So Dan, thank you very much. This is there is so much wisdom and grace in the work that you've done for all these years, and to see it really come to the model that you're presenting to us today is really, really moving and as well as important. I think we live as the title of our upcoming conference is in uncertain times. You know, there's a lot of reasons why the context is betraying our best intentions to do the right things, and is acting as to prevent our protective factors from helping us. So I think the more we are aware of how to really navigate these waters, I think the better we'll be in our own individual lives and in the work that we do with clinicians. I see there are questions coming. I'm going to start with one that I think from a personal one, I had to do that. Clearly, the modules, the psychoeducational modules that you are like a very important component for the integration of the individual and the family work. And as you highlighted, it really adds a great deal of flexibility to what the clinician can do. It occurs to me also that is one area of your work that it allows for the creation of context-specific modules that are not created by you, that somebody that is working in Liberty City, somebody that is working in Homestead, somebody that there's a reality there that needs to be addressed, can then create a module that really speaks to both the individual and the family issues. So my question to you is, at first, is by nodding, it sounds like that I'm in the right track on that. But the other thing is that what suggestions do you have for the creation, or what process do you go in the creation of new psychoeducational modules?
And that's a great question and a great perspective. We believe that when you're thinking of a module, you think about why would I do this, right? One is to normalize, right, the experience, right? So that people, when they see it in their lives, they don't get hopeless and this is just my family going through this. So when someone in the community says, you know, this is a community specific risk factor, right, or process, and you can bring it into a module and just start a discussion, right? Part of what we think about that modules do is create a readiness. A module creates a readiness for a family to work on something. Yeah. And so the minute that you say, here's something we see in our community, here's something that we know that it impacts families negatively in this and this and this way, not yours, right? Families. In this and this and this way, it's natural for that to happen. It's painful. And you can teach that. And then you can move to your family session later and say, how does that look in your family? And then by then they're more ready to say, yeah, you know, what's going on with other families, I can see that, happening with me. And then what would you do about it? How could you help the family get past that, right? So the module and the therapy session sort of interact in that way. Mm-hmm. I'll give you an example. When we were doing self-harm and we began to get lots of LGBTQ kids coming in, and we became more and more attuned to what was happening in the families, right? Mm-hmm. Rejection in the family, how some of the systems that parents used for support, right? Maybe a church, right? Actually now they couldn't turn to the church in order to, figure out how to be accepting and validating of their child. And mm-hmm. So we made a module around that. Here's things that happen, right? Families may struggle to accept, and youth might disclose to some members and not others. And that creates tension in families. And so here's how that happens, right? Not in your family, in many families. Now let's talk about, and it creates a readiness, right? To then say, okay, what does that look like in your family? And to what extent is this true? And how can we work through, giving your own protective factor? Yeah.
And what in your experience, since you've done it with a lot of different ethnic groups, and for whom many issues of spirituality are very important, and this is a recurring topic that has come in different presentations that we've done. People wanting to learn a little bit more about how to bring in spirituality to the sessions. Is this something that you do also in these psychoeducational models?
That's a very interesting point. We don't have it as a psychoeducational module, but it's something that we talk to therapists about a lot, right? There's been some very interesting, surveys, right? That the families that come into a therapist are often much more attuned to the spirituality than some of the therapists are. Therapists just don't, that's not where they're at. They haven't been trained or been given permission, right, to integrate that into a therapy, right? So the way we think about it is that the therapist must be very attuned, right, to the family, to eliciting a discussion with the families about what their support is, and many times it's spirituality or a church family, and one can't just go past that, because if we really believe in protection, right, in protective factors, right, and they're telling you this is one of mine, then we have to really be prepared to work through that. So we don't have a module specifically. What we have thought to do is to, try to make therapists very mindful, right, of being, of seeing that protective factor, yeah, and identifying it quickly. But it's a great point, because it's absolutely a big piece of the lives of many other families.
Mm-hmm. Thank you very much. I have a question from Dr. Gina Jefferson. So I believe if it's the same person I think it is, she might be presenting with us at the conference in May. So do you think about the possibility of these simulations looking outdated because they show people with clothing, etc., that reflect the times? Just curious about your decision making. I have wondered about it when thinking about using real people.
That's a great question, and our work is brand new. This simulation actually came out like a week and a half ago that I'm sharing with you, and this is the conversation we're having. How do we create a context that's different, that's more like the families that we work with? In fact, I was talking to my colleagues, and I was saying, one of the scenes is a kitchen. And I was saying, our next step is to create a kitchen with a Cuban coffee maker right there. I want a can of Café Bustelo right on the table. I don't want it so modern looking, because it's these, they're a little too modern looking for us. So the fun of this, right, is that we are hoping to create scenarios that connect even better, right, with many families. And we may have to pick different ones, right? We may have to say, this one may be particularly helpful for, this particular family. But absolutely the clothing, I can show you the whole history of the characters that we've created and trying to change their skin tone, right, to not make it, extremes, or to make it look like, like the people we work with. And clothing is going to be another important part of it, and setting is going to be another important part.
And please don't leave the Café Bustelo out, because it's you have support from the audience. Gabriela Uber is asking how to get trained in this module, in this model of working.
It's something that you can contact me. We provide it for people that are funded through the Children's Trust and are doing CIFFTA specifically. But this is really brand new. I mean, I've been doing training on CIFFTA for a long time, like individually with agencies in the old traditional method of going out for a couple of days and things like that. But we're really moving to this system because I just think it's more sustainable. And so absolutely anyone who's interested, contact me and we can figure out how to make it available.
We'll make sure that we have your contact information also included.
Yeah, it's actually on the last PowerPoint slide. I didn't get to it.
All right.
But please share it, yes.
The question, can you say more about the online platform and where it might not only be as good as, but superior to the more expensive in-person training?
Right. So I tried to mention a little bit of this before, but I think it has more opportunity for practice, right? For practicing. No matter how much, role play you do, it's always uncomfortable. It's always artificial, even in role plays on trainings. And we believe that this online system, with the way we've developed the interactivity, really allows you to play with different things and allows you to shape over and over again your communication, and with feedback from an expert, right, on how you can make it better. I think it's a much more cost-effective and tailored and focused way of doing the work. Practice, practice, practice. Someone said it's absolutely correct. I'm a true believer. Well, by the way, there's a literature. When I was teaching family therapy, there's a literature from a feminist perspective, from a race perspective. Ken Hardy, talking about the fact that it's one thing to have something conceptually in your head, and you can agree that racism is not a good thing, but how do you take it from here through your mouth into an intervention that you're comfortable with, that's respectful, right? That's not putting people off. That's what practice is, right? And getting feedback and practicing, and if we want to get good at it, we have to practice. So the individual said, practice, practice, practice. Thank you. You're right.
Question, can you say more about how the family level protective factors work, since it's central to your work?
Yeah, this issue of protection, of advocacy, right, of support, right? Again, this issue of issues of racism, right, of marginalization. These are real things out there. That's why I wanted to talk about risk factors separate from protective factors.
Mm-hmm.
Because the things that we can mobilize in families are truly, truly powerful. The fact that the family can be there, right, to give adolescents a talk about how to handle racism, how to handle anti-Latino sentiment, staying with them, sharing their experiences, right, validating. If a kid has a bad experience out in the world, it's very different if the parents are there to validate them and to talk it through than if the kids feel that they're on their own and they're more likely to just blow up because I don't have anyone to talk to about this.
Right.
And if we can really enhance that ability for that communication, support, mentoring to happen in the family, and maybe it's not parents, maybe it's a peer, right? I'm a strong believer that when we work well with a sibling, for example, a sibling can be an extraordinary support for a youth that's struggling. And it's something we often miss. We forget to do. Oh, that sibling is doing well. We don't have to bring them to therapy. They're doing well. Let's focus on this one. No, on the contrary. Let's engage that sibling so that we can use their protective factors in the session. Some of our best successes have been when we brought a sibling into sessions to be there to teach and to support the main youth we were working.
Thank you very much. I have a specific question here. How do you recommend asking about immigration experiences and acculturation stressors?
Yeah. We have two ways. I have a great partnership with Richard Cervantes in California, and he created a measure called the Hispanic Stress Inventory. And one way that we have done this is that's just a measure that people report on at the beginning, because then we use that in our profile, right? And it asks questions about immigration stress, acculturation stress, economic stress. So it's a little bit long, but it's a very nice tool that some people use. Otherwise, what we have is within our CIFFTA model, we have a clinical interview, family interview. And we ask tell me about the family history, right? And we have very specific questions. Tell me about the family history. How did you guys come together? It's almost like a genogram. How did you guys come together? Why did you decide to immigrate? What was the reason behind it, right? What was the impetus for you to decide? Was it an easy decision or not? Did you guys talk about it or not? How's it been, while you're here? So it's a really a specific series of questions in a very non-judgmental way, right? That develops trust and engagement. You have to be careful not to be like an FBI agent, because then families sometimes, right? But it has to be in a very natural, right? That's why practice. It can't be, okay, are you documented? That doesn't work. Right. But it's a very real way of getting to know the family, and to be able to say every once in a while, wow, that's a strength that your family decided this, that you took this step. That's a strength. I imagine that comes with a lot of pain as well and loss. Is that something you want to talk about? And it's a way of opening those doors and showing sensitivity to it.
And another question here from Tina Marie Del Blanco. And she's asking about whether the changing modules that you use and have developed over time have been evidence-based. Is there like an evaluation component about those? How do you know which ones are working well and support the evidence with evidence?
So that's a great question. We have not looked at each one separately. So we've evaluated the whole model when we use the interventions. Now, some of them we picked from the beginning because we knew they were tested in other interventions. So for example, we did borrow from Marshall Linehan's dialectic behavior therapy, interpersonal effectiveness for kids, emotion regulation, distress tolerance. So some of those have been used in other evidence-based treatments. I think it's a next step for us to really test each of the pieces. But in this model, it's a lot of pieces. And as you know, because of the tailoring, the configuration of one family is totally different from the other. So the way we've tested it is if we pick the modules that are relevant for the person and we do individual and family, how effective is the model altogether? That's the way we've tested it.
So it looks like you're going to be busy for the next 30 years with that part.
I thought I was semi-retired, but I don't think so.
Dan, this has been lovely. It's been really, really informative. It's an incredible amount of information, and it's congratulations to you and to your team. I know you work with people for years on this, and people in academia, in hospitals, in the community, and they continue to do that. And I think it shows, it's a way of thinking and practicing in clinical work that is responsive to the needs of the communities that we're trying to help. And it's admirable to see it happening like that. So I'm glad that you came here. I wonder if you have some other thoughts that you want to share with us before I close up.
No, just again to thank you for the extraordinary work that the Melissa Institute does for our community. We need you. We need you all, and we're grateful that you have done all of this, that you do all of this training and you stick with us. We have tried to make sure that the voices of the families we've worked with over 30 years get incorporated into the work. And we're grateful for all the families that have participated.
So I don't know exactly what to do with it, but I know Don Meichenbaum raised a hand here and I don't know, does that mean that you would like to say something? I don't know if I don't have the power to connect you, Don, or maybe you wanted to wave to so maybe Elise or Amanda.
Don's,
I don't know if
he can talk if we gave him the floor if you want.
Oh, Don is there. Yeah, Don is there. I see it. Okay.
I just wanted to thank you for a magnificent presentation. I think your work is transformative and creative and and will have a significant impact on the field of psychotherapy, especially your training modules. And the research indicates that deliberate practice with feedback on a session-by-session basis is going to be an important supplement to your efforts. Thank you once again for your presentation.
Oh, thank you. So I don't know how to say that, how honored I am to have Dr. Meichenbaum, first of all, listen to me, but to give that feedback. Your contributions to the field are just extraordinary, and we're so very thankful that you're with us and collaborating with us.
Thank you, Don, for joining in with your words of wisdom too, and thank you, Dan. And I want to remind the audience that what you witnessed today is what we aim to do every month, every time we reach out to you, bring innovations in clinical practice, innovations in violence prevention, the best knowledge that we can, and the best scholars to help us think in creative ways about these difficult issues. Everything that the Institute does, as many of you know, we do it for free. We kind of like try to provide to you the information that we can at no cost. All we ask in return is that you do two things, that you make an earnest effort to integrate it into your practice, into the life of the people that you work with, into the communities that you serve, the organizations that you help, and that you consider making a donation to us. So when the time comes, and if the situation allows you, click the button and send us a donation so that we can continue doing the work the way we do it. Thank you, Dan, and I invite everybody to join us on May 6th on the safety, mental health, and healing during uncertain times. It's going to be a wonderful conference, including Don Meichenbaum, including Dan Santisteban, including Victoria Baniar, including Lina Agumeres, including Gina Jefferson, and many others. So please join us. Bye-bye.
Thank you. Thank you so much. I put my email there in case anyone needs it.
All right.